Yep.
All right, what's our first one?
Anterior drawer test.
All right, you're gonna have to take a break from lunch. Put that over there. Patient is lying supine on the table, arms at their side, completely relaxed. Make sure that they also have their feet up on the table. No, I'm at this one, sorry. For the camera, I'm gonna do this one so you can see it, so you can stay there. Hip is gonna be flexed to 45, knee is gonna be to 90. Patient's position, I'm gonna be sitting on the dorsum of the foot to stabilize it. I take my 2 index fingers and they are in the popliteal fossa, making sure the hamstrings are relaxed. And my thumbs are alongside the tibial tubercle. So number 3, how to perform the test. I am going to attempt to translate the tibia in an anterior direction. Number 4, what structure am I testing? It's the ACL. And number 5, what dictates a positive test? So this is going to be laxity compared bilaterally. And then in all of our Starkey Ayres stuff, I wish I had found this right away. For the anterior drawer test, you can see I'm defining laxity compared bilaterally, meaning there is either 3 millimeters of additional anterior translation compared bilaterally, or if the affected leg comes out at least 10 millimeters, that is a positive finding. Pain is not a positive finding for this test because there's no way that we would know pain is emanating from the ACL. What's next?
Lachman's test.
All right, Lachman's test. Patient is same position. Camera can stay there. Arms at their side, they must be completely relaxed. I am going to be alongside the patient. Generally speaking, your inside hand should be on the lower leg. So for instance, I don't want to do this, I'm going to be here. So with one hand, I am going to grab the femur just above the condyles. With my other hand, I'm going to grab the proximal tibia, making sure my hand is on the posterior side. And then to perform the test, I like to just put the hip in just a little bit of external rotation. This is just an Andrew preference because it relaxes the person. I'm going to flex the knee to 20 to 25 degrees. In performing the test, all I'm going to do is just pull the tibia forward. And so what I'm looking for is how much translation is coming forward. So if there's more, 3 millimeters of laxity greater compared bilaterally, that's a positive finding. Or if there's 10 millimeters unilaterally, I know if it comes out 10 millimeters, it's torn. I don't have to test the other one. And that is a test for an ACL tear as well.
Slocum drawer test.
Slocum drawer test. I'm going to do it back over on this leg. So lying supine, arms at their side, completely relaxed. Hip is going to be at 45. Knee is going to be at 90. But this is a rotatory instability test. So it's like the anterior drawer test with a variation. So I'm going to do 2 phases of it. One, I internally rotate 25 degrees. The other one, I externally rotate 15 degrees. I'm going to do the internal one first. So how this differs than the anterior drawer is the anterior drawer, I was only looking for laxity in this plane. When I internally rotate, I'm elongating the medial side. So this is now a test for anterior medial rotatory instability. Lateral side, you're right, just like I said right there. Thanks, AJ, lateral side. So my position, I am sitting on the dorsum of the foot. My 2 index fingers are under the hamstring to make sure it's nice and relaxed. thumbs alongside the tibial tubercle, and then what I am going to do is pull forward on the tibia. So as I said before, this is for anterior lateral rotatory instability. Positive finding is increased laxity compared bilaterally. In a moment, I'm going to tell you what the structures are. But just to show you the other portion of it, she externally rotates to 15 degrees. I'm back on the dorsum of the foot. Index fingers making sure hamstring tendons are relaxed, thumbs alongside tibial tubercle, and then I pull forward again. So when I do that, I am putting tension both in an anterior direction as well as the medial side because I've elongated this. So when the foot is externally rotated, this is for anterior medial rotatory instability. So you can relax, and we're going to come over to the good old-fashioned Starkey error sheet, and you can see on page 2, what I would recommend is you guys just memorize this chart right here. So this can be applied for all rotatory instability tests. So when I was testing right then for anterior medial, I am testing these structures. And for it to be positive, I have to have 2 or more of those structures compromised in at least 2 planes. So when I had it up here, and internally that's anterior lateral, if there was laxity with that, that means I have 2 or more of these structures involved in 2 planes. What's next?
Lateral pivot shift test.
Patient is lying supine, arms at their side completely relaxed. Scoot just a couple inches towards me. There you go. My position, I'm alongside the patient with one hand. I am going to go ahead and grasp on the medial malleolus here. With my other hand, I'm going to take my thenar eminence, I'm going to find the fibular head, and I'm going to go ahead and, when I perform this test, flex the hip, passively flex the hip about 20 degrees. You relax, pass it. Then I'm going to internally rotate the tibia as far as I can. Then I'm going to go ahead and provide a valgus force. Why are you laughing? You're not being a good model. All right. So internal of the tibia, valgus, and then I'm going to move her up into flexion. A positive finding here is when I hit around the 40 to 60 range of knee flexion, the knee is going to spontaneously reduce itself. And this is for anterior lateral rotatory instability. Now you don't have this question yet, but at some point you're going to say, wait a minute, how can this be for lateral instability if I'm providing a valgus force? Shouldn't that be stretching this out? And my answer to you is if you look at this being the femur with the 2 condyles, this being the tibia, what I was actually doing when I was internally rotating is I was subluxing the joint between the rotation and the valgus. And then as I'm moving up into flexion, it spontaneously reduces itself. So in order for me to sublux one condyle on another, that means she has 2 or more structures injured in 2 different planes. So anterior lateral rotatory instability, you would use the chart again. It's primarily used for an ACL though.
Jerk test.
Okay. So there's 2 different ways to do the jerk test. I'm not going to get hung up on this. When I just did the lateral pivot shift and I brought you up, that's the flexion phase of this. Some people consider as you return the knee into extension to be the jerk portion of the test. So lateral pivot shift up, jerk coming back. So if that's the case, when it was up here, it was reduced. And when I brought it back down, when it hit 40 to 60, it subluxed again. But I would be remiss if I didn't tell you some people do a jerk test where they bring the person, she's starting in the knee at 90 degrees. I'm taking my thenar eminence, internally rotating the tibia, valgus stress test, so now I've subluxed it. And so now when I come back down and I hit 40 to 60, it reduces itself. And that is for anterior lateral rotatory instability. What do you guys do? You're gonna tell me later?
Crossover test.
How can that be funny? All right, crossover test. Stand up.
Ow.
Sorry. I'm gonna show something first. Okay. So, I'm gonna be the patient on this test. Crossover test, if I'm testing this knee, means the unaffected side, I'm either stepping behind or I'm stepping across and in front. So what I'm gonna do, because the camera is there, is I'm going to first go ahead and step over, across, and in front. And now you can see that my hips are facing this way. So this is not part of the test. But what I'm gonna do in keeping this position with my hips there and my back foot there, oh my goodness, I'm gonna attempt to sit down. So remember, my hips were facing there, my foot was facing there. So in this position, with my foot turned to the inside, I have stretched out the anterior lateral side of my knee. So that's what I'm stressing. Okay, so stand back up here, face that way. Okay, so patient's position, feet shoulder width apart. All right, now I want you to take that leg and step across to the other side. If she does that and she expresses instability, anxiety, or the sense that it's gonna go out, that is a positive finding for anterior lateral rotatory instability. Now, do the same thing, you come back around like that. Now she is stretching out the anterior medial side. So if she expresses the feeling as if it's going to go out on her, that represents anterior medial rotatory instability. So it would be 2 or more structures that's on the error sheet. I think that's all 4 parts, all 5 parts. What's next?
Posterior drawer test.
All right, supine up on the table, arms at your side, relaxed. I'll do this one. This is just like the anterior drawer test, so hip at 45, knee at 90, plantar aspect of the foot on the table. I sit on it to support it, index fingers underneath the hamstring tendons, thumbs alongside the tibial tubercle. But instead of pulling forward like the anterior drawer, I'm gonna be pushing back. So obviously I need to bring it forward to push back. And this is a test for the PCL. So what I am looking for is increased laxity compared bilaterally. But we don't apply that 3 millimeters, 10 millimeters, because the research wasn't specifically done on the PCL. Now, while you're recording, I'll give you kind of a test question here. Since I'm going back and forth, I don't care if an ACL or a PCL is torn, you're gonna have translation, right? So how do you know which one it is? How do you know if it's the ACL that's torn or the PCL? That's one way. How else?
Would you put it in a neutral position?
But how would you know where neutral is? The key is knowing where the end point is. Because right now, if she had a torn PCL, it would be starting further back, right? Gravity is pushing it there. So if I pull forward, it's like, whoa, it comes all the way out, but I have a firm end point. that actually means it's her PCL that's torn. I was starting further back. So it's the same thing. If I tell you it's going back and forth, but there's a firm endpoint all the way at the end of the PCL, that tells you it's an ACL that's torn. Little added benefit. What's next?
Godfrey's test.
Patient is supine, arms at their side. Scoot a little bit closer. That's fine. Hip and knees at 90 degrees. So she's completely relaxed, holding it right up here. This is what I was just mentioning before. If her piece, so this is a test for the PCL, clinician's position is off to the side. I'm looking at the level of her tibial tuberosity. If her PCL is torn, gravity is pulling her tibia down, and I'm gonna see a step off or an indentation where her tibial tubercle would be. So that's a positive finding for a PCL. Obviously, it would have to be at minimum a grade 2 or a grade 3, a partial or full tear. If it was a grade 1, it's not gonna sag down.
External rotation test or dial test?
Patient is prone, arms at their side, completely relaxed. My position, I am at the end of the patient and I'm going to grasp the plantar aspect of both feet closer to the calcaneus. 2 phases to this test. I'm going to passively flex her to 30 degrees. I'm also going to do this test when she's passively flexed to 90 degrees. But coming back to 30 degrees right here. What I am going to do is externally rotate both of her tibias as far as she can go. Then I'm going to do it at 90 degrees and externally rotate as far as she can go. A positive finding is that the affected side externally rotates at least 10 degrees further than the unaffected side. So, if it's a positive finding at 30 degrees, the structure involved is the posterior lateral corner of the knee, so you would use the Starkey error sheet for the structures. If it is greater than 10 degrees at 90 degrees, what she has torn is her PCL. And if it is greater at both 90 and 30, she has torn both. What's next?
Posterior lateral or posterior medial drawer test.
Okay, flip over on your back. So she's getting right back into that same position as the posterior drawer test. Scoot up so your heels are up there. Not that one. There you go. I'll do this one here. Hip at 45, knee at 90. So think of this like the Slocum drawer test when she went in 25 degrees and out 15. I don't know why the book says 15 and 15. We're splitting hairs about that. But if I put her into external rotation of the tibia, the 15 degrees, and I'm doing the posterior, what I have done is elongated the lateral side here. So now when I get my fingers underneath the hamstring tendons, I have my thumbs along the tibial tubercle, I'm pushing in a posterior direction. I am checking for posterior lateral rotatory instability, and a positive finding is increased laxity compared bilaterally. Use the chart to go ahead and make sure you identify what specific structures would be involved. Then when I go ahead and internally rotate, I think 25 degrees is fine. I know the book says 15. Now what I'm doing is I'm elongating the medial side, and since I'm pushing posterior, what I'm actually checking here is going to be posterior medial rotatory instability. Check the structures on the sheet. What's next?
External rotation recurvatum test.
Recurvatum test. Okay.
Recurvatum.
Your position is okay. So she's supine, arms at her side, completely at the table. What I am going to do is I am going to grasp the first ray of her foot. So that's the metatarsal and phalanges. And I am going to passively flex her hips and just lift them up. What I am looking for, a positive finding here, this is for posterior lateral rotatory instability, or you could have an ACL tear, and some of these findings would be positive as well. The positive finding is you're going to see more recurvatum, so this knee is going to sag down more. You're going to see more varus on this knee. You may see more internal rotation of the tibia and or more external rotation of the femur. So this knee here is essentially going to bow out and hyperextend. And that's for posterior lateral corner, or it could be the ACL.
Quadriceps active test.
Okay, let's get you into that anterior drawer position. So hip at 45, knee at 90. This one, you probably don't want to sit on the foot because I need to be down here to see this, so the clinician can be to the side. So I'm going to stabilize so her foot doesn't move here. And I'm also going to go ahead and stabilize proximal to her knee so she's nice and relaxed. This is actually a test for a PCL tear. And so what happens right now, if her PCL is torn, her tibia should sag down. But I'm going to instruct the patient to contract her quadricep, but she's going to do it by attempting to slide her foot on the table, but not actually moving it. So I'm gonna hold it right here, and she's just gonna contract, just like that. So she can relax and contract again. Relax and contract. So what would happen here, if she has a torn PCL, is it's gonna start back. When she contracts her quad that's over here, it's gonna pull the tibia forward. Then when she relaxes, it would come back. When she contracts, it would come forward. So you're looking at the tibial tubercle to see if that is moving in relation to the opposite side. So once again, it would have to be at least a grade 2 or grade 3.
Valgus stress test.
Her position is fine. She's supine, arms at her side, completely relaxed. With one hand, I'm gonna go ahead and hold the medial malleolus. With my other hand, it's going to be on the lateral aspect of the knee. And what I'm going to do is provide a valgus force first at 0 degrees and then at about 20 to 25 degrees. Relax. There we go. Just like that. So the structures that I'm testing, when the knee is at 0 degrees, I'm testing both the MCL and the medial aspect of the joint capsule. When I bring her into 20 to 25 degrees, it is just isolating the MCL. Positive finding for this test is going to be increased laxity compared bilaterally. I'm also going to check the integrity of the endpoint, so I know if it's a grade 2 or 3. And the last thing it could be is pain over the MCL. Is Ferris next?
Varus test.
All right. Varus test, same position for her. The clinician can do it 2 different ways. So if you could have the lateral malleolus with one hand, medial aspect of the knee with the other, but when you do that, you can see like my body is leaning over. So some people like to go ahead and sit down because it's more comfortable for them. Either way is fine. I'm first going to test her knee at 0 degrees. So I'm going to provide a varus force, that's right here. Then I'm going to passive, nice and relaxed. There you go. Then I'm going to do it again at 20 to 25 degrees, and it naturally will open up a little bit more. So when I do it at 0 degrees, it's both LCL and joint capsule. When I do it at 25 degrees, I'm isolating the LCL. Positive finding for this is increased laxity compared bilaterally. Pain over the LCL, and I'm also checking the integrity of the endpoint.
That's it.
Is that one? You want to stop the video?